very much for attending. As mentioned, my name is Kathy Walker. I'm with the Indiana Rural Health Association and am the program director for their tobacco dependence program. And I'm going to start off by talking about treating tobacco use and dependence in the clinical setting. And this is from the clinical practice guidelines. There's some recommendations. So I'm going to go ahead and get started with that. So the introduction to the clinical practice guidelines, these were put together actually a number of years ago by these 8 federal government and non-government organizations. So some good strong organizations with some expertise in the area. So I won't list those, but you can see them there. So very, very well put together, very respected. It's kind of our gold standard in tobacco dependence, nicotine dependence. The clinical practice guidelines are. So this is kind of what they look like. They provide an evidence-based strategies, an effective treatment. They are for clinicians, tobacco treatment specialists, healthcare administrators, insurers, and purchasers. Because as we know, in treating any type of chronic disease, which tobacco dependence is a chronic disease, yes, it causes many chronic diseases and is the cause of, but it in itself is a very strong addiction and is categorized as a chronic disease, even though many times we don't look at it that way, but it really truly is. The recommendations were made due to this systemic review, and some specific topics were identified by the panel, and they're listed here. Quit lines are very effective. Combining counseling, medication versus counseling or medication alone is really most effective. We're talking about varenicline, which Karen Hudmon, my partner from the Purdue School of Pharmacy, will be talking more about medication, so I won't belabor some of those. And then there are, some behavior changes and some interventions for some specific populations that it looked at. And here are some other specific demographics that the clinical practice guidelines looked at. And so there are some guidance in the clinical practice guidelines for these things. So I encourage you, this is just an overview. I encourage you as clinicians or administrators, insurers, purchasers, whatever, to take a look at the clinical practice guidelines online and look at your area and see what you can do to improve your systemic addressing of nicotine dependence. So 10 key recommendations are in the clinical practice guidelines, that it is a chronic disease. I've already mentioned that. And as with any other chronic disease, it requires repeated interventions and multiple attempts to quit. Tobacco, and talking with a lot of tobacco users, I have many friends and family, and I've taught classes myself. It's one of the hardest things that there is to quit. And it does take multiple attempts. And so we need to use these effective treatments that have been mentioned in the clinical practice guidelines, and that will help increase successful quit attempts that are long-term. Number 2, it is essential for clinicians and healthcare delivery systems to consistently, every time you see a patient, as you would with any chronic disease, ask about it. Are they still using tobacco? Are they using tobacco? Are they vaping? Are they doing any form of nicotine? Falls into the tobacco treatment aspect. So ask them about it every time you see them. Ask, advise, refer is what we recommend. And do it in a really non-judgmental way. Tobacco-dependent treatments are effective across a broad range of populations, so we need to understand that and know that, and encourage your patients that are willing to make a quit attempt to use counseling treatments, medications. We have a Quit Now Indiana, the tobacco quit line in Indiana that's very effective, and it's free, and it can provide some nicotine replacement therapy to qualifying enrollees. Number 4, brief tobacco dependence treatment is effective. I mean, we need to mention it again every time you see a client, a patient, and do some brief interventions. And while you may feel that it doesn't do any good, it does plant a seed. And every time you mention it again, it becomes a reference point, and it can help to build motivation and interest in quitting. Individual, group, and telephone counseling are effective. The quit line, as I mentioned, is effective, and it can increase the treatment intensity. Practical counseling, problem-solving skills, social support are all part of the quit line program and any kind of nicotine tobacco dependence treatment program. A lot of times they need to learn other ways to manage stress, to manage a lot of things. So there's a lot of behavior change that goes on, and social support is critical, very, very, very important. There are numerous medications available for tobacco and nicotine dependence. And again, I won't go into this too much, as Karen will talk extensively about that. Encourage your patients that use tobacco to get counseling and to use the medications. So it is helpful. There is some insufficient evidence for some forms of tobacco, pregnant women, smokeless tobacco, but a lot of that is changing. And we do have a special program for pregnant women through the Quit Line that's really tailored around that demographic. Numbers, here's the medications. There's 6 first-line medications, 2 are nicotine, 2 are non-nicotine. And again, Karen's going to talk about this, so I won't really go into this too much. But it is something to have a discussion about with your patients in terms of what might be a best fit for them. Again, in combination with counseling or a Quit Line referral is best. Again, counseling and medication are effective when used by themselves for treating, but they're even better if they're combined. And that is documented quite well in the clinical practice guidelines. The telephone Quit Line counseling is effective and across a diverse population and has broad reach. And it's free, and it's over the telephone. It can be web-based, text-based. It's very versatile in terms of meeting people where they're at and utilizing current technology. If a tobacco user that you're seeing as a patient is really unwilling to make a quit attempt, really encourage you to utilize motivational interviewing techniques. They're fairly straightforward. There are classes and things and trainings you can take around motivational interviewing. But again, even if they're not willing to make a quick attempt, because they do need to be willing to quit to be successful. It's not something that anyone can force someone to do if they're not interested. So, but we can motivate them, making it relevant to their situation, to their family, personal health issues, whatever it may be. We can do that through motivational interviewing techniques. So, and then in terms of insurers and providers, a lot of insurance companies do cover nicotine medications and counseling. So, and if they don't, we really want to encourage our insurers and purchasers to do so. But it's really a cost-effective treatment. So those are the 10 recommendations from the clinical practice guidelines. It's broken into 7 different chapters, and I'm going to mention those here just briefly so you can find where you might want to look within the guidelines for your area of interest. It's pretty easy to use. So I'm just sharing this for your reference. Smokers with comorbid medical conditions such as cancer, cardiac disease, COPD, diabetes, asthma, heart disease, any of those kind of things. We know that tobacco use exacerbates those conditions. So those in and of themselves are motivating factors for people. Sometimes not motivating enough, but that speaks to the strength of the addiction. So I'd encourage you to be compassionate, empathetic, and also encourage and try to motivate people to move forward with their quit attempts, because it can really, it can't, like for example, COPD, it's not going to make COPD go away if someone quits smoking, but it may help it, likely will help it from getting worse. So these are teachable moments, as noted. So we want to really use those opportunities to teach, to motivate, and really quitting, is the best way. Cutting down is a start, but it's so easy with the strength of this addiction to go right back. And even after a successful quit, recognizing and accepting that you can't have another cigarette, you can't have another hit off a vape, because it's that strong of an addiction that you can go right back in a very short order. So understand that. It is chronic disease management, so we want to incorporate tobacco dependence in those systems, and we can help with that at IRHA in terms of helping. We have some toolkits we can provide that will help to identify areas that may need some work to make it a disease management program. Incorporating referrals to the quit line into your EMRs or EHRs, whatever, is very helpful and efficient. And again, nicotine addiction is nicotine addiction in any form. So just understanding that. Future trainings that we can do as a starting point from this is combination therapies, pharmacotherapy, which we're going to be including here today, system interventions, and special populations. So please feel free to reach out to me if you have any interest. Here is where you can find, there's a link here, I can put it in the chat. To the clinical practice guidelines for reference. Yeah, and I'll get that in the chat here in a bit. So this is my contact information. Please feel free to email me or call if you'd like to chat about this in more detail, or if your system or organization is interested in improving your tobacco dependence treatment programming. We are also offering an assessment for your organization. If you would be interested in taking it, I'll send this link as well. It will help. It's an extensive assessment. It maybe take 10 minutes or so to complete, but it will help to identify areas of need within your organization. And the date there is incorrect. Please disregard that. I apologize for that. But I'll put those two links in the chat for you. Any questions on this at this point? Comments? Otherwise, we'll move on to Karen Hudmon from Purdue University School of Pharmacy.
I'm working off a laptop today because I am out of state. So if something pops up in the chat, I likely won't see it. So Kathy, if you could just let me know if there's any questions that come while I'm speaking. So my name is Karen Hudmon. I'm a professor of pharmacy practice at the Purdue College of Pharmacy. I am a pharmacist. And I've been working in tobacco treatment and controls for almost 30 years. My My mother died of lung cancer when she was diagnosed at 49, and she was dead at 50. She was a former tobacco user, smoking cigarettes, and she had quit more than 5 years before her diagnosis. So one of the things that we know is that you always carry risk with you forward with respect to cancer. Some of the risks can be reversed over time, especially with cardiovascular disease, but as Kathy mentioned, COPD is not one of those. Some of the lung problems that people have aren't reversible, and cancer is not reversible. A former tobacco user will always remain at a higher risk for cancer compared to people that never use tobacco. But by quitting smoking, you can eliminate additional risk that would be added associated with continued use of tobacco. And so today I'm going to talk about the medications. And when we think about helping people quit smoking, quit vaping, quit using smokeless tobacco, or really any form of nicotine, there are two parts. There's two parts to smoking and there's two parts to quitting. So there's that strong behavioral aspect, but there's also a physiological addiction to nicotine, the drug nicotine, which we have in not just tobacco cessation medications, but really in all forms of tobacco. Now we're looking at vaping products. We're also looking at nicotine pouches and trying to learn how to get people off of those. So, but today I'm going to talk a little bit kind of high level about the medications that we currently have. And then I'm going to focus in on a new medication that's on the horizon that's under review at the FDA. And that is called Cytisine. And I say new, it's technically not new. It's been around since 1964. And I'll tell you a bit more about that in a moment. But first, let's start with what do we have now on the market that has an FDA approval for smoking cessation. Note it doesn't say vaping cessation. It doesn't say smokeless tobacco cessation or hookah or anything other than smoking cessation. But we use it for treating all of the above, even though the indication is for smoking cessation. That's why I have it in quotes. And so we have 3 over-the-counter non-prescription products, the gum, the lozenge, and the patch. This is the standard dosing for starting regimens. We also have another nicotine-containing product, which is the nasal spray. And you might not be very familiar with this because, quite honestly, not many people use it. If you were to take a prescription to a pharmacy, chances are very high that they would have to order that medication. It will not be on their shelf. So, and that's not a problem. They can get it in the next day typically. But it's one that, these are the 4 that we have that have nicotine in them. We call them nicotine replacement therapy because it has nicotine in it. The other 2 medications that we have that have an FDA approved indication for smoking cessation are bupropion SR, where SR stands for sustained release, and we dose it generally every 12 hours. Or varenicline. Both of these are tablets. They're taken by mouth, and they both have an indication for smoking cessation. Bupropion SR is also a chemical entity, is also used for depression. You might be familiar with the brand name Wellbutrin. It's been around a long time, longer than I've been in pharmacy. And it was discovered that it helped people get off of tobacco, and so it was studied for that, and in fact, it does help them quit. And then varenicline was the newest product on the market, but it has since gone to generic. It's been on for a long time. And that was back in 2006 when it was introduced. So we're looking at 20 years since we've had a new medication, okay? And so I'm hoping this next one makes it through the FDA. And I'm going to talk a little bit about the differences here in a moment. So this is what we have. This is standard starting dosing here for all the medications that we currently have in the United States for using for smoking cessation. Now, how do they compare? Okay, well, this is a table that combines lots of studies. 105 studies of the patch versus placebo, 71 for bupropion SR versus placebo, etc. And so as you can see, this is a heavily studied concept, smoking is, in the medical literature. And what we know by combining similar studies, they're not identical, but they're similar enough that we feel comfortable pulling the data together to see, like, on average, how well people do with quitting. And what we have in the right-hand column are what we call odds ratios, and that is simply a comparison of one group to another. So the active drug versus placebo for all of these. And so, for example, the nicotine patch, if you were to use a patch compared to people using a placebo patch, your odds of quitting is 40% higher than somebody on placebo. If you use bupropion, it's about the same. If you use any short-acting nicotine replacement therapy, the only ones we have now are the gum, the lozenge, and the nasal spray. It's about the same. And we know that these are statistically significant because if you look at that 95% confidence interval, Those ranges, like 1.2 to 1.6, for example, in the first row, do not include 1.0. If it included 1.0, that would mean that it was not statistically significant. Now, there's a lot of things that go into significance, including sample size, etc. But bottom line is they're not, these are all effective. Combination NRT, which typically involves the nicotine patch, which is a long-acting nicotine formulation, kind of gives you that steady backbone, in combination with one or more short-acting nicotine products like the gum, the lozenge, or the nasal spray, nearly doubles your chances of quitting because the odds ratio is 1.9. If it was 2.0, it would actually be a doubling. Now, what's the highest number here? Varenicline, 2.3. And that's their odds of staying off of tobacco for 6 or more months, up to 5 years. Okay, and so 2.3 more than doubles your chances of quitting compared to placebo. Now, can I compare 1.9 to 2.3 and say varenicline's better? Not really, because they're different studies, but it kind of tells you a story here, right? I would say that my starting point for most patients, unless there's a really good reason not to, would either be varenicline or combination NRT. All the ones above used as what we call monotherapy, meaning used alone with no other, like not in combination. I would not start people on those anymore. Typically, it's combination NRT or varenicline, unless they're on a very low level of smoking, and then I might consider the patch. But I wouldn't lean toward short-acting medications alone, like the gum, the lozenge, and the nasal spray, simply because you have to dose them so frequently throughout the day if you're using them alone. In fact, you start the gum and the lozenge with a minimum of 9 pieces per day, so it's a lot of dosing. But what we see here in this analysis, which is called a meta-analysis, combining all the data and looking at it, is that we have pretty strong evidence that combination nicotine replacement therapy and or varenicline are more effective than bupropion SR and nicotine replacement therapy as monotherapy. All right, so that's what we have. That's our medications and our armamentarium. And what we now are going to look at is looking at varenicline, because we know it's very effective for helping people quit smoking. But we've got a vaping problem in this country, and it didn't happen overnight. It's been growing over time. We're seeing reductions in smoking in a lot of populations, but we're seeing concurrent increases in vaping. And so what we see here is a study that was conducted by Caponetta, Italian study, and they looked at a 12-week, which is standard dosing. We typically dose people for 12 weeks. That gives them time to learn how to become a non-smoker, again, deal with the behavioral parts while their addiction to nicotine is being treated. Remember, 2 parts to smoking, 2 parts to quitting. So we treat the addiction with the medications to make them more comfortable while they're learning to quit. And then while they're learning to quit, they're able to develop stronger coping strategies, etc. So we do these hand in hand, behavior plus medications, for almost all patients. So it was a 12-week double-blind randomized controlled trial with 12 weeks of follow-up. And so they had 140 adults who were only vaping every day, but they were also ready to quit. So they gave them varenicline using the standard dosing that I showed on that second slide for 12 weeks compared to placebo. And both arms had behavioral counseling. So 10 to 15 minutes, 12 sessions. So essentially every week for 12 weeks, which is what we would like to see. We want strong behavioral counseling components. And what we find is that in weeks, let's just go to the bottom row here, weeks 4 to 24, when they have continuous abstinence, meaning they didn't smoke at all, the odds of staying quit were 34% versus 17% in the placebo. So it was significant at p-value less than 0.05, so it's 0.02. So what we saw was that varenicline was effective in adults for helping them quit smoking up to 24 weeks. Okay, and so there were very infrequent, not treatment-related serious adverse events. And so you might recall that varenicline and bupropion SR at one point had a boxed warning on it, which is the FDA's most important, prominent, highest level of scrutiny when you're working with the patient level of concern. And the boxed warning is something that led to a substantial reduction in the use of varenicline for quitting smoking for several years until it was removed in 2019. And they did a study. It was a large study. It was a randomized trial, and it showed that the serious neuropsychiatric events that they were observing or that were being reported with varenicline were not related to the drug at all. In fact, it wasn't. They had a study with varenicline bupropion SR, the nicotine patch, and placebo. And that study, which was very well conducted, actually led to the removal of the boxed warning, which is, I believe, the only the fourth time in history that had occurred. So we now know that varenicline, or have pretty good evidence that varenicline wasn't causing those problems, and it might have been a side effect of quitting. All right, so we've established, although there's no indication, like FDA indication on the labeling for varenicline for vaping cessation in adults, we know that it has some success. And we're starting to use that in my teams and our group programs, et cetera. We're starting to use varenicline more and more. But what about for kids, like youth, young adults? So there was a study that was conducted and was published in JAMA very recently, as last year. And they looked at youth, young adults, 16 to 25 years old. They were daily vaping. They were ready to reduce or quit, but they were not smoking cigarettes. There was no combustible tobacco product on board. What they did was they compared varenicline to placebo to just usual care, which was tech support. So they didn't get anything really other than the tech support. So standard dosing plus counseling plus tech support for 12 weeks, or placebo plus counseling plus tech support for 12 weeks, or just tech support. And so what they found was that varenicline in combination with counseling, which we always recommend the counseling, significantly improved vaping cessation rates in the study population, which was 16 to 25 years old. And quite frankly, we don't have a lot of evidence for this population, but this is a population that we really need to know what to do, because they're the ones that are using these products in very high levels now, especially the people in their early 20s. And so if you look at the data here, there were very few adverse events, no treatment-related serious events. And you can see, if you look at the orange bars, that's weeks 9 to 24. Again, continuous vaping abstinence, which means not even a puff. 28% for varenicline versus 7% in placebo versus 4% in enhanced care. So to me, this is pretty strong data. Do I wish it was higher? Absolutely. But this is what we get with tobacco treatment. We don't get really high quit rates. We find that people who use the medications appropriate, use it for the longest, like for the full duration of treatment, like 12 weeks, for example, and get strong behavioral counseling, definitely have a better odds of quitting. But unfortunately, most people kind of bail on their treatment. So we don't see really high quit rates really for anything. So this is the first good data that we have. I think a pretty solid study published in a really good journal that gives us some evidence for varenicline. And by the way, I didn't say this, but varenicline used to be called Chantix. So Chantix was a drug that was initially introduced by Pfizer. And then at one point, they identified some trace amounts of nitrosamines in the tablets. They voluntarily withdrew the product from the market, and they say they were going to bring it back, but it's been years now and they haven't brought it back. And besides, by that point, there were generics available. So I don't think we'll be seeing Chantix ever again in the United States from Pfizer. I'd be surprised, because with the generic market being so robust right now, many different companies making it. All right, so enter the new but really old drug, cytisine. So cytisine's been on the market in some countries in Europe since 1964, the year I was born. And it does have success, but it's been dosed in a very bizarre way. But first, let me just explain a little bit about it. It actually comes from, it's an alkaloid, and it comes from the golden rain tree. And so it's actually derives from a natural product. And it works the same way that varenicline works at what we call the alpha-4 beta-2 nicotine acetylcholine receptor. And it binds to that with less affinity than varenicline, meaning it's not going to bind as strongly or as often. But when it does bind, it does two things. It sets off some stimulation, like, you get some stimulation from varenicline, which makes you feel better, but not as much as you would get with a cigarette. And so for varenicline, we say that it's like a 40-watt bulb in a socket versus a 100-watt bulb that you would get for nicotine from a cigarette. I'm not sure what, kind of where this one falls if I had to pick a wattage for a bulb, but probably less than varenicline. But the other thing that it does, it binds at the same receptor site. So if you have bound to a receptor site with a drug, it's then occupied. And that then means that other nicotine that might come along if you slip up and have a cigarette. It's not going to feel as good. It's not going to give you the same, oomph that you would normally get, because there's going to be nicotine circulating around and there's nowhere for it to park. I always think, like to use the analogy of like a Target parking lot. There's only so many spots, right? If they're occupied by the drug, then the nicotine is going to be circling around. It's not going to have anywhere to go, and that's going to get broken down. It's not going to have any effect. So it has two mechanisms. That's how it works. Partial agonist has some stimulation effect, but then it also competes at the same receptor site. Bioavailability, the half-life is almost 5 hours. And so when I look at that, half-life is kind of how long it takes your body, how long a drug lasts in your body, until it becomes half of what it was. And so what's interesting about that is it's pretty long half-life. I mean, it's not really long, but it certainly doesn't warrant the dosing that they have had on Tabex, which is the brand name for Cytisine in Europe. And if you look at this here, from days 1 to 3, 1 tablet every 2 hours, maximum 6, and 4, so it's just crazy dosing. It's very difficult for patients to manage, but when you have a half-life of, let's say, 5 hours, you don't need to take it every 2 hours. So there was a company in the United States that said, wait a minute, why are they dosing it like that? Maybe we can get this product, reformulate it, have it 3 times a day dosing, and see how it works. And that's what they did. It's called Achieve Life Sciences. They have, it's under phase 3 clinical trials right now. It has a new drug application at the FDA, and they're stating that there's a target action date or some kind of decision to come mid-June of this year. And so we might be having a new medication on the market. But what is this drug? Well, like I said, it's now going to be dosed 3 times a day instead of the crazy dosing that was on the previous slide. And what they're looking at is using this for vaping cessation and actually studying it and having it go forward to potentially get an indication from the FDA for vaping cessation. And if that is true, if this goes through, this will be the first medication ever that we have to have that indication. Not to say we don't use the other ones, but to have that on the labeling. And so what they did was they conducted 3 milligrams 3 times a day for 12 weeks versus placebo. Continuous abstinence until the end of treatment was their measure. They had a 31.8% quit rate versus 15% for placebo, and it was significant. And so well tolerated, less than 4% discontinued treatment. And so that's kind of where we are right now. These are called the ORCA trial, and there's some other studies that have been conducted. I'm not going to cover all of them, but just to kind of give you a summary of where we are now, we do know that, varenicline is, I always say, the leader in the clubhouse. I like sports analogies. I'm a Steelers fan. And so I think it's a leader in the clubhouse still, and might remain so. I'm not sure whether cytisinicline or cytisine, whichever one you want to call it, it's the same thing, is going to be better. And if it's similar but not better, and it's dosed 3 times a day versus varenicline, which is dosed twice a day, I mean, depending on the side effect profiles. I mean, I think I just need to wait and see what the data show, which one I would recommend. If they're really similar, I will always recommend the medication that's twice a day versus 3 times a day, because adherence is an issue. So there's something to think about that. Short-term trials suggest that it's safe and effective. There's ongoing follow-up for longer-term outcomes with cytisinicline, but the jury's still out. But I think the jury's looking pretty good for approval from what I can tell. So we do know that varenicline does have some success with vaping cessation in adults and youth, and there doesn't appear to be any major negative side effects that we can see so far. Of course, when you launch it on an entire population, sometimes some things show up. They might be real signals or they might not be. We don't know, but anyhow, that's an option. And right now, that is what we are doing. For most people that are vaping that we want to have quit, we will give varenicline. And sometimes in combination with a short-acting nicotine replacement therapy agent, such as the gum or the lozenge. That gives them a little bit of latitude. And then depending on how much nicotine products they're using, the gum or the lozenge, if it's a ton, then sometimes we will transition them over to, say, a 7 milligram patch in combination with varenicline, and still give them the option to use a short-acting if they need it. So the thing about helping somebody quit vaping is you really need to have high touch points and frequent touch points. We recommend the first follow-up to be within 24 to 48 hours for people quitting vaping, because we're really just trying to estimate the amount of nicotine that they're getting from their vaping devices. It's difficult to calculate. I strongly recommend that you work with clinical pharmacists because they can help with that. I mean, I teach my own students how to calculate nicotine dosing and, to figure out how much nicotine people are getting from these vaping products. And we don't really know. First of all, we don't know what's in the pens. I mean, some of them are basically self-compounded. They make their own e-juice. Other ones come as is, but they're not regulated very well, so it might not actually have what it says on the label. But then when you inhale, and this is true for cigarettes as well, people inhale very differently. Some inhale very deeply, hold it for a long period of time before they exhale. Other people puff on it gently, maybe let a cigarette burn before they actually puff much out of it. So there's this whole thing about, we call it like smoking topography. It's almost like, like a map, with the elevations. But we have the same thing with vaping. Then we have so many different devices, so many different e-juices. It's very hard to know. There has been a study published that tells us a little bit about how much actually comes out of the pen and becomes bioavailable to the individual. But, then how much they actually inhale is another question. So we're just guessing, I guess, is the bottom line. And so that's why it's so important to have very quick follow-up after helping somebody and prescribing or recommending medications for them. And in the same breath, I'm going to tell you that in the state of Indiana, pharmacists can prescribe tobacco treatment medications. They can prescribe all of the medications, and they can do it for vaping cessation as well. And so they have to have had the appropriate training. That is a requirement. But if you go to a website called quitsmokingpharmacies.com, you can find pharmacists in the state of Indiana, and actually nationally, that are actually doing this actively, this type of treatment. And so I just want to also comment on bupropion, SR, and nicotine replacement therapy in general, that there's not a lot of published evidence. That doesn't mean it doesn't work. It's just we haven't had enough studies to show that these do for helping patients quit vaping. So what we do a lot in vaping is we lean on what we know from smoking cessation. And so if it works for smoking cessation, it probably will work for vaping cessation, because your brain cannot differentiate between nicotine from a cigarette, nicotine from a vape pen, nicotine from nicotine pouches, nicotine from a hookah pipe, nicotine from a patch, gum, lozenge, nasal spray. Nicotine is nicotine. What matters, what's the difference, is how fast it gets there, and that is what leads to addiction. And so how quickly it works in that area of the brain where nicotine lives, basically in the ventral tegmental area, largely prefrontal cortex. So I'm going to stop on that, and I will open up for any questions you have. And I'm also going to go back to my first slide, which has my email address, khudmon@purdue.edu. That's Hudmon with an O. And I'm always happy to answer questions later as they arise. So I'm going to stop sharing here. If I can get my mouse to work. There it goes. It's not really working. Okay. Okay. Happy to answer any questions. Enough to chat now. I'm going to put my email in here. And our state grant is called Rethink Tobacco Indiana. We work largely in the mental health and substance abuse space. So, but I do work a lot with Kathy Walker in the rural health population. So, anybody have any questions about the meds? Anything? Okay.
Thank you, Karen, as always.
Always a pleasure.
Back to you, Carolyn.
While we're waiting on some more, questions to come through, if they have any, I'm going to launch our other poll.
Thanks, Debbie, for posting the link to our website. I didn't see you were on because I wasn't looking at it. The website for the pharmacists here. And the way that works is pharmacists actually prescribe under what we call a standing order, which is a prescription that's written by the state health commissioner. So they write a prescription under Dr. Boggs, Dr. Weaver, whoever it was. And they're given that authority through legislation. And it requires that everybody that they write a prescription for receive a 14-day follow-up, and that they are contacted at the end of treatment. So, and they must also not just prescribe the medicine and talk with them about the medicine, but they have to either provide behavioral counseling therapy themselves, or they have to refer to the Guideline or some other evidence-based resource. So they really do get comprehensive counseling, really comprehensive treatment when they do engage with the pharmacist in this manner. Good. I guess everybody gets 15 minutes of their day back, right? Kathy, did you have anything else?
I don't really. Just would encourage you to take a look at the clinical practice guidelines, and please consider doing our tobacco-free agency assessment. We are here to assist with health systems change activities and have lots of good resources, and are more than willing to help. So.
Yeah, and Debbie just alerted me that there was a question in the chat, which I did answer, about regarding Chantix. And yeah, so we do have the generic, and that is very similar. And then, of course, the new one, if it makes it through the FDA, which I think it will. I don't see why it won't. It's a matter of time and evidence. So, because it's been on the market since 1964 elsewhere, used differently. And that is all I know. I know of no other medicines that are being studied at this time. You know, the thing about tobacco treatment is it's really a short-term gig for most people. You use it for 3 months, basically, sometimes 6, where pharmaceutical companies are more interested in medicines that people are going to take for their life, right? It more return on their investment. I mean, it's sad, but it's true. So. But I also think we have a lot of meds. We're very fortunate. And if people were to use them correctly, they could really be helped.
Yeah.
So.
And again, it's, the meds address the physical aspects of nicotine addiction, but there are some behavior changes that need to occur as well. And so that's why you need to have the Guideline or any kind of, evidence-based counseling program as well. Very important.
Like 1-800-QUIT-NOW.
Yeah, right. Exactly.
All right. Okay. Well, I don't see any other questions. So, Carolyn, tossing it back to you for a wrap up.
All right. Yep. I don't see any more questions either. So I just want to thank everybody again for joining us today, and have a great day.
Thanks. You do the same.
Thank you.
Thanks, Kathy, for having me.